Good day, everyone. I am Jana Servo together with my partner,
Kevin James Guizon
from College of St. John Rojas, second year nursing students. And we are going to discuss about the drugs for bones and joints disorders.
Characterized by polyarticular symmetric joint involvement and systemic manifestations. The disease is 3 times more common in women. Rheumatoid arthritis, often known as RA, is an autoimmune and inflammatory condition in which your immune system unintentionally assaults healthy cells in your body, leading to inflammation in the areas of your body affected. It primarily targets joints, typically a number of joints at once. For the pathophysiology, RA results from dysregulation of humoral and cell-mediated immunity. Most patients produces antibodies called rheumatoid factors. Phagocytosis produces enzymes within the joint. In RA, the autoimmune reaction primarily occurs in the synovial tissue. Collagen breakdown: the enzymes break down collagen, causing edema, proliferation of the synovial membrane, and ultimately pannus formation. Pannus destroys cartilage and erodes the bone. The consequences are loss of articular surfaces and joint motion. The clinical manifestations are joint pain, swelling, warmth, erythema, and lack of function. This is the pathophysiology figure of the rheumatoid arthritis. Rheumatoid arthritis therapy is used or directed to reduce symptoms like pain, inflammation, and stiffness. It maintains joint function and range of motion. It minimizes systemic involvement and delay disease progression. To achieve these goals, a combination of pharmacologic and non-pharmacologic measures is used. We have the non-drug measures. It includes physical therapy, exercise, and surgery. Physical therapy consists of massage, warm baths, and applying heat to the affected areas. These procedures can enhance mobility and reduce inflammation. Enough rest and exercise can decrease joint stiffness and improve function. But too much rest and exercise should be avoided because too much rest will foster stiffness, and too much activity can intensify inflammation. For patients with severe disease of hip and knee, total joint replacement can be performed. The patient should be informed about the rheumatoid arthritis, like the possible consequences of joint degeneration, management measures, and the benefits and limitations of drug therapy. Drug therapy: anti-arthritic drugs can produce symptomatic relief, and some drugs, if started very early in the disease process, can induce protracted remission. However, remission is rarely complete and the disease typically advances steadily. As a result, drug therapy is chronic and success requires patient motivation and cooperation. Classes of anti-arthritic drugs: we have non-steroidal anti-inflammatory drugs or NSAIDs, glucocorticoids, and disease-modifying anti-rheumatic drugs or DMARDs. These major groups differ with respect to time of course of effects, toxicity, and ability to slow rheumatoid arthritis progression. The NSAIDs provide rapid relief of symptoms but do not prevent joint damage and do not slow disease progression. The NSAIDs are safer than DMARDs and glucocorticoids, thus treatment with NSAIDs requires less vigorous monitoring. Like the NSAIDs, glucocorticoids provide rapid relief of symptoms. They also can slow disease progression. But although glucocorticoids are effective with long-term use, they can cause serious toxicity. As a result, treatment is usually limited to short courses. DMARDs are drugs that reduce joint destruction and slow disease progression. DMARDs are subdivided into two basic groups, the non-biologic DMARDs and biologic DMARDs. Non-biologic DMARDs are small molecules that are synthesized using conventional chemical techniques. Biological DMARDs are large molecules that are produced through recombinant DNA technology. Both have significant adverse effects, therefore close monitoring is required. Non-steroidal anti-inflammatory drugs or NSAIDs are drugs of first choice for rheumatoid arthritis. Owing to their efficacy and rapid onsets, NSAIDs provide only symptomatic relief. They do not slow disease progression. Accordingly, they are usually combined with a DMARD. NSAID classification, we have first-generation NSAIDs that inhibits COX-1 and COX-2. Second-generation NSAIDs inhibits COX-2. The anti-inflammatory and analgesic effects result from inhibiting COX-2, whereas major adverse effects, especially gastroduodenal ulceration, result from inhibiting COX-1. Therefore, the selectivity of this drug class results in less gastrointestinal ulceration than the first-generation NSAIDs, while producing equal therapeutic effects. For its dosages employed for anti-inflammatory effects are considered higher than those required for analgesia or fever reduction. Glucocorticoids are powerful anti-inflammatory drugs that can relieve symptoms of severe RA and that may also delay disease progression. Most often, glucocorticoids are used for temporary relief until drugs with more slowly developing effects like methotrexate can provide control. For patients with generalized symptoms, oral glucocorticoids are indicated. However, if only one or two joints are affected, intra-articular injections may be employed. Because long-term therapy can cause serious toxicity like osteoporosis, gastric ulceration, and adrenal suppression, short-term therapy should be used whenever possible. Long-term therapy should be limited to patients who have failed to respond adequately to all other options. The commonly employed oral glucocorticoids are prednisone and prednisolone.
Methotrexate is a disease-modifying anti-rheumatic drug and is considered the first-line treatment for rheumatoid arthritis. It works by suppressing the immune system and reducing the inflammation in the joints. So there are several benefits to using methotrexate in the treatment of rheumatoid arthritis. Firstly, it effectively reduces joint inflammation and pain. Additionally, methotrexate has been shown to slow down the progression of the disease and help prevent joint damage. So,
Before we proceed further, it's important to address the safety alert associated with methotrexate. So methotrexate can cause numerous and potentially fatal toxicities of the bone marrow, liver, lungs, and kidneys. Other fatalities have occurred associated with skin reactions and due to hemorrhagic enteritis and gastrointestinal perforation.
non-biologic disease-modifying anti-rheumatic drugs are a class of medication used to treat autoimmune diseases such as rheumatoid arthritis, psoriatic arthritis, and systemic lupus. So unlike biologic, which are derived from living organisms, non-biologic are chemically synthesized and do not involve biological components. They work by suppressing the overact immune response that causes inflammation and damage to the joints and other affected tissues. So here are some examples of non-biologic disease-modifying anti-rheumatic drugs. Methotrexate. So methotrexate is one of the most commonly prescribed non-biologic disease-modifying anti-rheumatic drugs. For the treatment of rheumatoid arthritis, it is an antimetabolite that interferes with the production of DNA and RNA, thereby suppressing the immune system's response. Methotrexate is often used as a first-line treatment and can be taken orally or administered as an injection. So these non-biologic disease-modifying anti-rheumatic drugs are typically prescribed by rheumatologists and are effective in reducing symptoms, slowing down disease progression, and improving the quality of life of our patient with autoimmune conditions. So it's important to note that this medication may have potential side effect and their use should be closely monitored. Again, biologic is are derived from living organisms such as proteins or antibodies, and they specifically target K molecules involved in the immune response. So this medication help reduce inflammation, slow down disease progression, and elevate symptoms. Next, another example is adalimumab. So marketed under brand name Humira, is a biologic disease-modifying anti-rheumatic drugs that belongs to the class of tumor necrosis factor or TNF inhibitors. It is widely used in the treatment of autoimmune diseases such as rheumatoid arthritis. Sulfasalazine, under the brand name of asulfidine or asulfidine A in tabs. It can slow the progression of joint deterioration and sometimes with just 1 month of treatment. For GI reactions, nausea, vomiting, diarrhea, inorrhea, and abdominal pain. Dermatologic reaction, pruritus, rash, urticaria, adverse effects, hepatitis, and bone marrow suppression.
Leflunomide, under the brand name of Arava, is a powerful immunosuppressant indicated for adults with active rheumatoid arthritis. In clinical trials, the drug decreased signs and symptoms and slow disease progression. So for adverse effects, diarrhea, respiratory infection, reversible alopecia, and rash. Here, other non-biologic disease-modifying anti-rheumatic drugs. First, penicillamine. Second, gold salts. Next is azathioprine. Next is cyclosporine, minocycline, and lastly, protein A column. So, first, penicillamine. So, penicillamine can relieve symptoms of rheumatoid arthritis and can delay disease progression. Next is gold salts. So, gold salts have been used in rheumatoid arthritis for decades. So, treatment can relieve pain and stiffness and may also delay disease progression. And next is azathioprine. So, azathioprine is an older DMARDs with immunosuppressive and anti-inflammatory action. Serious toxicities include hepatitis and blood dyscrasias. So the next is cyclosporin. So cyclosporin, under the brand name of neural sandimmune, an immunosuppressive drug used to prevent rejection of transplanted organ, can reduce symptoms of rheumatoid arthritis. So the next one is minocycline. So minocycline is an antibiotic in the tetracycline family, has been used experimentally in rheumatoid arthritis management. So lastly, protein A column. So the Prosorba column used in combination with plasmapheresis, so decreases the titer of circulating immune complexes that promote symptoms of rheumatoid arthritis. So the next slide, drugs affecting calcium levels and bone mineralization. So calcium is critical to the function of skeletal, nervous, muscular, and cardiovascular system. So more than 98% of calcium in the body is present in bone. So bone undergoes continuous remodeling, a process in which osteoclasts resorb old bone and osteoblasts lay down new bone. Calcium in bone. So the vast majority of calcium in the body is present in bone. It is important to appreciate the bone and the calcium it contains. It is not static. Rather, bone undergoes continuous remodeling, a process in which old bone is resorbed, after which new bone is laid down. So the cells that resorb old bone are called osteoclasts, and the cells that deposit new bone are called osteoblasts. So both cell types originate in the bone marrow. Vitamin D is obtained through the diet and by exposure to sunlight. So vitamin D deficiency causes rickets in children and osteomalacia in adults. Deficiency may also contribute to certain autoimmune disorders and cancers, although convincing evidence is lacking. Calcitonin. So calcitonin, a hormone produced by thyroid gland, decreases plasma levels of calcium. Hence, calcitonin acts in the opposition to PTH and vitamin D. So calcitonin is released from the thyroid gland when calcium levels in blood rise too high. So calcitonin lowers calcium levels by inhibiting the resorption of calcium from bone and increasing calcium excretion by the kidney. So unlike PTH and vitamin D, calcitonin does not influence calcium absorption. So for the next slide, calcium salts. So calcium salts are available in oral and parenteral formulation for treating hypocalcemic states. These salts differ in their percentage of elemental calcium, which must be accounted for when determining dosage. Calcitonin salmon. So calcitonin salmon, a form of calcitonin derived from salmon, is similar in structure to calcitonin synthesized by the human thyroid. So calcitonin salmon produces the same metabolic effects as human calcitonin but has a longer half-life and greater milligram potency. The drug is usually given by nasal spray, but can also be given by injection. Intranasal calcitonin was removed from the Canadian market in 2013 due to an increased risk of malignancy associated with this formulation. So for actions, calcitonin has two principal actions. So first, it inhibits the activity of osteoclasts and thereby decreases bone resorption, and second, it inhibits tubular resorption of calcium and thereby increases calcium excretion. So as a result of decreasing bone turnover, calcitonin decreases alkaline phosphatase in blood and increases hydroxyproline and urine. Therapeutic uses: osteoporosis. Calcitonin salmon given by nasal spray or injection is indicated for treatment of established postmenopausal osteoporosis, but not for prevention. Benefits derived from suppressing bone resorption. The treatment program should include supplemental calcium and adequate intake of vitamin D. So Paget's disease of bone, calcitonin is helpful in moderate to severe Paget's disease and is the drug of choice for rapid relief of pain and associated with the disorder. So benefits occur secondary to inhibition of osteoclast. So neurologic symptoms caused by spinal cord compression may be reduced. For adverse effects, with intranasal dosing, nasal dryness and irritation are the most common complaints. Studies demonstrating an increase in malignancies associated with nasal administration prompt withdrawal of this drug in Canada, but it remains available in the United States following parental administration. About 10% of patients experience nausea, which diminishes with time, and additional 10% from inflammatory reaction at the injection site. Flushing of the face and hands may also occur. When calcitonin salmon is taken for a year or longer, neutralizing antibodies often develop in some patients. These antibodies bind enough calcitonin to prevent therapeutic effects. Osteoporosis is characterized by low bone mass and increased bone fragility, which renders patients vulnerable and fractures from minor trauma. So the most common sites of osteoporotic fractures are the vertebrae, distal forearm, and femoral neck. So for the last slide, osteoporosis, to maximize bone strength and thereby minimize the risk of osteoporosis, we all need to first ensure lifelong sufficiency of calcium and vitamin D, and second, adopt lifestyle measures that promote bone health, regular weight-bearing exercise, and avoidance of smoking and excessive alcohol.